Welcome to this hybrid Nordic Health Talk about the future of the Nordic healthcare system, partly live from Arendalsuka here in Norway. My name is Siri Gulliksen Tømmerbakke, and I'm leading this debate on behalf of Molecule Consultancy in Denmark, Reform Society in Sweden, Ahjo Communications in Finland, and Kruse Larsen in Norway. The demographic development in the Nordic countries pose a challenging situation for the healthcare sector. In the coming years, we will have fewer personnel to care for an increasingly aging population. To solve this, we need to make changes. We need to find new ways of working and implement more technological tools. During the next hour, we will try to find the answers to what are the major challenges and trends in the healthcare systems across the Nordics. And we ask, what are the possible solutions? And what can the Nordic countries learn from each other? To help us find these answers, we will hear from experts from Norway, Sweden, and Denmark. Jesper Fisker, who just recently presented the report Sunnhetsstrukturkommisjonen to the Danish government. Gunnar Bovim, who led the Norwegian committee Helsepersonellkommisjonen last year and in addition was a member of the Danish committee. Lars Roxén, who is the vice president of the Swedish Medical Association. And while I'm sorry to say that our Finnish representative could not make it today, we will get some insights in what's going on in Finland, thanks to Hans Jakob Mo, business developer in Tieto Every Care, who is so kind to step in at a very short notice. Okay, we will start off with you, Jesper Fisker. In June, you delivered Sunnhetsstrukturkommisjonen's report to the Danish government. Could you just give us a brief presentation of your key findings and solutions?
Yes, thank you, and thank you for having me. Can you hear me?
Yes.
Excellent, thanks a lot. Yes, that's true. We last year we had a new government, or a couple of years ago, in fact, a new government in Denmark, and they presented ideas to a new structure of the Danish healthcare system. But when they finally had to decide on which way to go, they somehow ended up by having the solution of having this commission put up. So experts from Denmark and Gunnar from Norway should come up with proposals to the Danish government as to how to organize the Danish healthcare sector in the future. It was important that they decided that we should not come up with one solution. We should come up with different solutions and advantages and disadvantages of the different solutions. So we were not asked to come up with one suggestion. We were asked to come up with different proposals, and that's what we have done. And then we were asked to go through almost every area of the healthcare system in 1 year, which is totally impossible, and we tried our best, but that means that, I think that you probably could find, if you had another year, you could go even deeper into some of our accommodation, our suggestions. But we were asked to come up with solutions to the structure of the Danish healthcare system, and we were asked to do this without being prejudiced on how it is today or what are the possibilities in the future. The only thing we couldn't do was to change the structure of the Danish municipal system. We couldn't make a new municipal reform, and we could not alter how we deduct taxes in Denmark. So that these two barriers was the only things that we couldn't do. Otherwise, we were supposed to look on the entire health system. And what we set out in our initial discussions was to find out, so what is the most important thing? And we found that if you look at the Danish healthcare system, from a patient perspective, from a professional perspective, from an organizational perspective and a political perspective, we have in certain areas a fairly well-functioning healthcare system in Denmark. But if we look into the future, 20 years, we do not have the structure that can serve the challenges we have in the public sector in general and in the healthcare sector specifically. And the reason why that's a problem is the same as in the other countries, that we have an aging population, more comorbidity, a lot more illness between elderly people living in their own homes. So we have to sort of develop our healthcare system outside the hospital system. We've been pretty good at the past 20 years to develop the hospital systems, and it's fairly successful. The next challenge is to shift focus from the hospital system to the primary healthcare system, to the system outside the hospitals, but in closely cooperation with the hospitals. And that's what we set forward in our analysis and our recommendations, is to how do we do this? How do we actually come up with a proposal that will strengthen the healthcare system outside the hospital system? And that's basically what we have done. So you want to hear a little bit more about the how the recommendations are?
Yes, please, just in brief, if you could.
Yep. We've divided our proposals into two. We have the organizational models, 3 different organizational models. The first 2, both of them with a one-string system where you get the entire health system from the municipal level to the GP level to the hospital system within the same organizational framework. Then we have differences. In model 1, it's politically led by politicians elected by the population, and in number 2, it's more professional management-based system, but still with the same structure of fewer. With abolishing the counties, and now instead of the counties, then have 10 different organizational units taking care of everything from elderly care in the municipalities through GPs through to the hospital system. And then we have a model 3, which is more or less divided into the same levels as we have today, but a lot of different initiatives to compensate for the problems that we have, the existing structure. So 1 and 2, pretty dramatic changes. Model 3, not so dramatic changes. But then we did, from the beginning, we had a conversation in the commissions about what about all the important things? How could we sort of propose something that would not end up in, discussions on models where important initiatives in important areas would sort of be washed out through discussions about something completely different. And then we decided fairly early in the commission work that we would have 6 different initiative areas that we would suggest be taken care of no matter what organizational model we propose. And we have those 6 different areas of initiatives where we say, no matter if you choose model 1, 2, and 3, we suggest that you content-wise go with these 6 recommendations. And that's, the strengthening of the primary health system outside the hospital system, the strengthening of the GP system, a new digital infrastructure, more closely cooperation between psychiatry and the somatic part of the healthcare system, and other areas as well. And what's been, I think, good about that way of suggesting the initiatives is that has been received fairly positive, the 6 different areas where we should do something no matter what structural model you actually decide on. So what is in the present discussion, where the Danish government are working on their proposal on the background of the report from the Commission, I think, and the reaction also to the Commission report has been fairly, everybody's not agreeing, but backing that those 6 areas should be addressed no matter what. And then there is a big discussion politically on which of the three different models should be taken into account. But I think I'm fairly confident that content-wise, those 6 areas will play a part of the original or the eventual reform in the healthcare system.
You didn't point to one model from the committee. Why didn't you do that? And could you are also the head of the Cancer Society in Denmark. Do you have a preferred model you can share with us?
We were asked not to suggest a model, so that's why we didn't do it, basically. I think if you go through the members of the commission, we will probably all have our favorites, and some of the members of the commission has afterwards also spoken out about their preferences between the models. I still want to say that I think depends on the perspective, because if you started out by having nothing, I think model 1 and 2 would be the models where you can actually solve some of the fundamental problems in the Danish healthcare system, but it comes with implementation costs and transactional costs, because then you change a lot. Where if you use model 3, it's a lot easier because it's building on top of what we have already. So that maybe it doesn't solve the fundamental problems to the same extent as model 1 and 2, but it then is a lot easier to implement, and then causes less trouble within a healthcare system, which is pressed in Denmark as in all the other countries. So it basically depends on the perspective you have on pros and cons. But in general, I would say all the medical associations, the associations of other, the nurses, for instance, all the patient organizations, even the Dansk Industri, the Danish industry or association, they have pointed to model 1 as the model that should be followed, because it's more fundamentally taking into account that we need to do something fundamentally different than today. But I will not now come up with a solution. My organization has pointed to model 1 with other patient organizations.
Okay. Thank you so far, Jesper. Helsepersonellkommissionen, a lot of what Jesper Fisker talked about here, I recognize a lot of it from last year's big report from you, Gunnar Bovum. Could you please tell us?
I'm glad you do.
Yeah.
I'm glad you do. And thank you, Jesper, for your description. And we worked on top of what is the general feeling. We are getting older, we are getting fewer in the workforce, and this is a dilemma. The Danish Commission was about structure. Our commission was about health personnel. How can we recruit? What should be the best strategies? And in our work, we have a lot of proposals on how to increase the result of every health worker. And I want to say that having a meeting like this, comparing the Nordic countries, is a very good idea. We have a lot to learn from each other, and the others have something to learn from us. Everybody has advantages and disadvantages. The obvious easiest part in Denmark is, of course, the small distances, no mountains, no winter, and 98 municipalities. In Norway, we have the same population size, a lot of mountains, a lot of distances, and 357 municipalities. This is a huge political difference, especially in what Jesper mentioned as the third proposal from the Danish Commission. Our findings are, I don't think I should spend time in repeating all of them, because Jesper took them, but it's we have workforce with high education. We should try to improve the general knowledge of everybody. We should start building from below. And what I learned is that in Denmark, they have another composition of the working force, more lowest education level, but we have a lot of the upper, more expensive educations. And I think we should learn from that in Norway.
But when it comes to the structure, you also, or at least most of the commission agreed that something should be done. Could you just short?
We discussed that, of course, because we think that in Norway we have a lot of energy going into the collaboration between the municipalities and the hospitals. We think that there is a leakage of energy in this two-level organization. So it's not. I don't think I say anything which not everybody has understood. But I think that we should organize health service so that the whole patient progress is within one organization.
Sort of like Model 1 in
sort of
Denmark.
like Model 1.
Yeah.
Because the hospitals will always win on getting the resources. The municipalities will always lose, and the demography says that we have to increase in the municipalities more than we increase in the hospitals. This is politically very difficult. It's been a political goal for 20 years, and we're still struggling.
It's been 1.5 years almost since you delivered your report. What has happened in that time, in short?
We have got a white paper from the government stating quite some of the problems. On last Friday, 3 days ago, the government put their perspektivmelding, which is a white paper on what's coming up. And I think that the melody that it's not a money problem mainly. It is a people problem. It's clearer in this perspektivmelding than it has been before. So I think it's gradually coming to the political level, but I'm not certain that we've come to the point that it will be solved. And I would like it to come there sooner than what I can see from what I see outside now.
Jesper Fisker, how has the Danish people, and I don't mean the politicians, but the people, how they, which reactions have you seen from delivering your report?
Well, differently, of course. Depends on your point of departure and your organizational position. But I think, at least in my view, when it comes to describing the problem, I think more or less everybody agrees on that. So I mean, describing that there is a problem basically met with acceptance and acknowledgement that we've described the problems as they are, and this is necessary to do something about. When it comes to our recommendations, I think, as I said before, the 6 overarching proposals have been met quite positively from very many angles, politically, from the population as well, and also organizations of different kinds. Whereas when it comes to the specific organizational models, Model 1, 2, and 3, I think you can actually see where you're coming from when you're commenting on the different models. Like if you come from the regional level, it's evident that you think, that the regions play a major role. If you're from the municipal angle, the same thing. I think they think that the municipal angle should be more stressed. From the general population, I think, and that's one of many things I've learned from Gunnar on this journey, is that it was very important that we set a general agenda as well, because if you come up with solutions to a problem that no one really knows is existing, it's not gonna fly. So we've spent a lot of time in our commission to participate in talks and debates all over the country, visiting hospitals, visiting municipalities, organizations. So really paid a lot of attention to working with the Danish population, even the broader population, the patient level, patient organizations. So I think that has been part of the answer as to why our problem description and also some of our suggestions has been met. I think it's fair to say more positively than I would have expected from the beginning.
And you had a Norwegian as a part of the Danish committee. How did that happen, and what are your experiences?
Yeah, that remains to be understood. A Norwegian playing a role in the Danish context. What is this about, Gunnar? No, it's been a privilege, of course, to have Gunnar. I've learned a lot from him. I think, as I said, describing the problem, but also as you just said, Gunnar, hospitals always win. If you don't do something about it, you're just going to end up with the same result as ever if you don't do something organizational differently. And also process-wise, I've learned a lot where this Norwegian came up whenever, I was the chairman of the board, and whenever we disagreed on something, I would say, I was filled with the urge of making an agreement on things and, finding a mutual solution. We are going to just lay back or sat back in his chair saying, stay in the pain, Jesper. And that was a really good way of looking at it, that, difficult discussions, they have to be carried all the way through. Otherwise, we won't end up by, a unanimous report as we did. But, apart from the personal side, and thanks, Gunnar, a lot, and enjoyable cooperation with you, but apart from that, I think it's a very good idea to have this international cooperation between the different countries, and especially between our Nordic countries, because we have a lot of similarities, but we also have differences and different experiences. But the mutual ground is so common that we can actually learn from each other, where sometimes when you're interacting with other countries, you might have the same problems, but the structure of your health system is so different that it's really difficult to have this really mutual beneficial cooperation discussion about things. And I think that has been evident in our commission, that it's been a privilege, and it's been a better result that we had Gunnar on board. And I would recommend any future commission on things like that to invite people from other countries to this process.
Sounds like you had a blast in Denmark, just
it was very well chaired.
10 seconds, yes. Thank you. We will move on to Sweden, and we have with us Lars Roxén, who is the Vice President of the Swedish Medical Association. Lars, are you ready to share your thoughts?
Of course. Thank you for letting me attend this event. Well, in Sweden, we are looking to Denmark and Norway as examples of progress that we also need to address. We have not as many municipalities as Norway, and we have far more counties or regions than Denmark. We also share the geography of Norway, but we sadly do not have the economy of Norway. So we're struggling right now, and we have also identified the problem with the steering of the healthcare system from a national level through the counties and down to the municipal level. And as such, there's a commission, Vårdansvarskommittén, that has been working for a year now, which have the task to look into the structure of the Swedish healthcare system and how to govern it through all the different levels. That work has not yet been presented, but we're looking closely to the work that Denmark has done and that Norway has done. Norway was with your helseforetak were quite early in reducing the number of counties or regions in the Nordic countries, and we need to address that in a Swedish perspective as well. there's also it became very clear during the COVID pandemic that the governmental structure or steering of the healthcare system is lacking in when you have that many counties and municipalities that need to collaborate. So that's huge work that is being done right now, and I think that we'll end up as Denmark, that we'll find a couple of suggestions, but the Vårdansvarskommittén will probably not recommend one of those because that's probably up to the politicians. But
the Danish Medical Association did that.
I know, and we have strong feelings, and we will recommend, of course, but the committee will not, I think.
Like us.
Exactly. But a few things that we have been discussing in Sweden is the problem with the resources to hospitals were mentioned, and we have a similar problem in Sweden, where the hospitals are very resource heavy, and the primary care is lacking in resources, especially personnel. But right now our hospitals are also very heavily used, and the occupancy rate of almost all Swedish hospitals are close to 100%, almost always above 100%. So we're using more resources there in the hospitals. So removing resources from hospitals it's also difficult, even though we need to make that progression. And moving forward with this, the government agency in Sweden has set a goal for the occupancy rate in hospitals to 80%, which is a goal that the counties and the hospitals are having troubles with, because the personnel in 24/7 wards, emergency wards and similar, are leaving and will not accept to work in nights and weekends. So nurses are leaving and senior personnel are leaving. In the primary sector, it's a sort of a different situation, because there we have set a goal for 1,100 patients per primary care physician. That's an offensive. That's a really. It's a good goal. It will make the work environment for the physicians really good, and they will be able to focus on their patients. But in order to reach that goal, we have quite a long way to go. We lack several thousands of primary care physicians to reach that goal based on simple math. We lack somewhere around 3,000 or 4,000 primary care physicians to reach that goal. So that's a challenge, meaning in primary care we need physicians, and in hospital care we need nurses. In order for these goals to be met. And at the same time, we're struggling with rather heavy economical challenges, with almost all counties reporting large deficits during this year and probably in the next. So we have challenges ahead.
They sound very familiar, I think everyone can say. Thank you so far, Lars. Hans Jakob Mo, you're a business developer at Tieto Everycare, a Finnish company, but you're Norwegian and great, so stepped in at last minute. On Wednesday, you're participating in a debate who's called Look to Finland. Tell us, why should we look to Finland?
Yeah, I mean, as a Norwegian employed in a Finnish company, you tend to ask yourself what's so special with these Finnish people. They are among the happiest people in the world. Actually 2 consecutive years being awarded the most happy country in the world. I don't know if they like pain more than the other Nordic countries, but at least they have now put forward a health and social care reform in Finland.
The SOT reform.
Yeah, based on the same challenges that we have heard about now in Finland, Sweden, and Norway. Yeah. And I don't know if I'm going to describe a little bit about the history behind this reform.
Yeah, tell us what's so
because it's
different.
almost 20 years old. It started in 2005. Yeah, it started in 2005 with a political discussion around how do we secure equal access to health and social care services throughout Finland, acknowledging that there are very big differences between the urban areas with big university hospitals, with big municipalities providing health and social services, and a big difference when you see on the rural areas in Lapland, for example, where the accessibility to hospitals and social care was challenged. So I think the politicians in a way shared the same common challenge or question. How do we provide equal access to high quality health and social care? And what do we do? Do we trust that 295 municipalities can secure that same level of high quality care for the citizens? Or do we have to look at the way we organize this? And then, of course, after 3 or 4 governments, big debates, one government actually resigning due to not getting a put through of their suggestions. In late 2022, they agreed on the new way of organizing health and social care called the SOT reform. And the way it's organized is that they have now organized specialized care, so hospitals, university hospitals, the municipal care, and the social services into one organization. And there are 21 regions throughout Finland with these responsibilities. And then it's not up to each of the 295 municipalities to finance this. The state is now responsible for financing these services. And then, of course, you need some of that participation and knowledge from the municipalities. So there is a political level that are also voicing their needs into the regions. But it is the regions that are the biggest employers of health and social care workers, and they provide this care for the citizens. So in a way, to sum it up, it was this reform came about because of the same challenges as in Denmark, Sweden, and Norway, but also with a common understanding that health might be too important to people than trusting that 295 municipalities with very big differences in number of citizens will provide that same equal quality of care. So in a way, they are the front runner or test bed of new ways of organizing health and social care services in the Nordics.
I'm interested to hear from Fisker and Bovin. Is that something you look to when you worked with Helsepersonellkommissionen and Sunnhetsstrukturkommissionen?
Jesper, you start.
Yes, we were looking at different experiences in different countries, and we had a special analysis done by, I think it was Boston Consulting Group, going through experiences from Finland, Norway, Sweden, England, Holland, and other countries as well, in order to have a broader perspective for the Danish context. So we've looked into the Finnish experiences as well, and we're quite inspired by the way they've done things. And we've also had a visit from digitally, I think, from one of the founders of the Finnish model. And she was telling a lot about the Finnish context, and also saying that, hard experiences, they didn't have that so far, because it's even though they, they've discussed this, as you said, for 15 years, and they've been on the brink of deciding it, I think, 2 times in the Finnish parliament, and now they finally did it. but implementing it and having hard results on how did it really go is hard to get so early in the process. So we've been inspired by their thoughts and their considerations, but we've also been inspired by other countries in the way we're looking at things. I think what's been so evident for us in the Commission was that the description of the problems are basically similar in more or less all countries, especially in our Nordic countries, but also other countries. And then the point of departure is a little bit different because most of the countries, they've prioritized the decentralized part of the health system, primary care, more than in Denmark, where we have prioritized the hospital system, the specialized hospital system. And we've had success with that because we had, a lot of progress within cancer treatment, heart disease, and in other areas. But we've sort of missed out on developing the primary healthcare. And so we are starting out as a point of departure a little bit worse off than most other countries because they've already, even though you said from Sweden that you have, you haven't prioritized the primary healthcare enough. You've prioritized it more than we have in Denmark. So our point of departure, if you want to change this, is a little bit more difficult than in other countries.
And I think the key idea with the Finnish system is that the patient progress for almost all of the patients should be within one organizational structure, one boss for the whole patient care from home to the hospital. What we discussed is 21 then a too high number because many of the specialized hospital stays will have to be in regional hospital, which are not 21. So they have a problem on top of the model. But otherwise, it's more like the what we call number one or number two. But then again, the history is important and the geography is important. I think that the Danish system they can put more into the hospitals because all the hospitals are more or less within walking distance from where people live. But when it's 200 kilometers, then you have to really have some more backing at home. So that's why we have a somewhat different weight of this care. But then again, I think my feeling is that when we've had our system with 2 levels for a long time, we've benefited from that. But now it's time to start discussing one level, one boss for the whole patient process.
I will just agree with Bovim and also Jesper that it's too early to say maybe the outcomes of the Finnish Sutra reform. But at the same time, there's another perspective here. They have managed to put technology, and that's where we are fortunate to support them on developing data analytics that actually monitors how does this reform actually behaves in the regions. So the political debate is based on insights in a way. And one of the discussions in Finland as well is whether the number is too high. So whether they should reduce the number of regions. As Bovim said, there are 4 or 5 university hospitals. They provide for more than one region. So how do we make an efficient number of organizations providing this equal care?
And maybe if I could just add on here that we had exactly the same discussion in the Commission, and we went from 21 as a possibility because that would be more suited to working with the local municipality tasks and the primary health care, and then down to quite few units because that were more accommodating the specialized hospital system. So we ended up by 8 to 10 because that was the possibility of having a robust, well-functioning specialized hospital system on top of the well-functioning local focus from this unit as well. So that was why we ended up by having 8 to 10 as opposed to the Finnish version of 21. But as I understand the Finnish discussion, they also have or are at the moment discussing whether 21 might be a little bit too many in order to sustain and support a specialized hospital system. So it's a lot of balances in this discussion as well.
Lars Roxanne, we hear that I hear that they argue fewer regions, bigger regions, and more focus on primary care. But that leaves your big problem, the personnel. How do you think?
Sure. Let me just first comment on the discussion previously. We have one example in the northern part of Stockholm called 1000 Norrtälje sjukhus. It's a hospital where they have connected the municipal level, the social care level, and to the emergency care hospital. It has been running for 10 years. And very successfully with reservation for a couple of economical difficulties where the financing should come from. But that's a really interesting example, and I believe that the personnel is happy to work in that type of setting where you can take responsibility for the patient's entire journey from primary care to specialized care. But I also think that we need to keep two thoughts in the head at the same time. We need to at the same time decentralize the local care and at the same time centralize the highly specialized care in terms of organ transplants or neurosurgery and such things that are very resource dependent. So we need to keep those two thoughts and develop those two things at the same time. That's a challenge. Oh, I'm sorry about that interlude.
No, I was just asking what you see as the most crucial to get enough personnel, healthcare personnel in the future, because that's your biggest challenge, if I understood you right.
It's very clear that that's the largest challenge, and I think it's similar for all Nordic countries. And we need to make the work environment good enough for the personnel to make it possible for them to work in the 24/7 environment. That's completely clear, because right now we have a movement from the 24/7 emergency wards, and people are choosing, nurses especially, are choosing to work at day schedules, and that's a challenge. In terms of positions, I think the situation is slightly different, because I believe that we're educating quite a large number of physicians, but we need to make it possible for them to develop into the work environment and be participants in the healthcare system. And I believe that if we have a system where they can take responsibility for the patient, all of them are interested in helping the patient, and if we give them the tools to help the patients, then I think that's the way forward.
Do you think there are any cross-border recommendations or thoughts your Swedish Vårdansvarskommittén could maybe get some new ideas from?
Certainly, I know that they are working closely with looking at all the Nordic countries in terms of structure and discussing the organization and the taxation and financing of the healthcare system. But when it comes to personnel and solving that riddle or challenge, then we need to discuss. And I think there are things that we can learn from each other in terms of making the work environment good enough and making the personnel eager to work in the healthcare sector.
I just want to congratulate Sweden on this 1100 number for each GP, because I think it's necessary that the GPs to be the sort of coordinator for the patient progress. don't have too many patients, don't have a list which is too long, because they have to spend more time on each patient, and they should not send the patient into to the hospital care to let them spend the time. So it's the best resource way is to increase on the lower level, and primary doctors are the key to let this happen. Congratulations.
I completely agree, and thank you for that. We have been working with that several years from the Swedish Medical Association. But I agree, I completely agree, and it gives also the local communities and municipalities a clear goal to reach for, and they need to give resources for that development and to reach that goal. So it's a very clear goal, and it's very simple to understand how that, and that makes it very effective.
So you agree on the problems in Sweden and the challenges. My last question goes to each one of you. If there is one thing that your country could adapt from one of the other Nordic countries, what would that be? Don't say money.
I'll go ahead and start. I think one of the key ways forward are to collect the entire healthcare organization around the patient. So the organization have responsibility for all steps in the care of the patient. That's a key to moving forward.
And can you mention one thing, and maybe you just did or Bovim did for you, what other countries can learn from you?
Well, I have the two targets, I think, the 1,100 patients per GP and the 80% occupancy rate in the hospitals.
Yeah. Jesper Fisker, do you want to answer these two questions?
Well, lots of different things that we could learn. Probably, when it comes to development of the primary healthcare system, I would look anywhere to have good experiences in order to build that as good as possible in Denmark. And there are things to learn from other countries. I'm always also very envious on the 1,100. We have 1,600 patients per GP in Denmark at the moment. And one of the key issues also for the Commission was to suggest initiatives that could bring them down, especially for those having patients with social inequalities and different difficult health issues. So that would be very interesting for us. And then again, I would look very much to the Finnish experience when you start to come with more hard evidence or outcomes from this reform as to how does it actually work when you have one boss in the system. I'm looking forward to the first experiences there, because I think that's very interesting.
Gunnar Bovim?
I think in Norway we need to discuss whether we should have a municipality reform or whatever we should do as the Finnish to have this one boss for the patient progress. But I think the number in Finland is too high.
Do you want to take the Finnish perspective again?
I don't think I'm the right person
Okay,
to actually suggest something to Finland. So they should look at what happens in Denmark and Sweden and Norway, and I think they do. But I think when you look at these reports that has been published, all the reforms that are tried out, I think there's two things that we should keep in our head. That's how do we actually secure the best possible patient care. And then if we look at this as a sustainable challenge, how do we move from maybe a reactive healthcare system where we wait for patients to get sick and start to do more on prevention? And there you need data to actually see what we can do to prevent people from getting sick.
But we know this, but still no one does anything. I think in Norway 9% of the total budget is for prevention, and the rest is for treatment or rehabilitation. So
Yeah, I
it's
don't know
easier
if
said than done.
Bovin, what did you suggest?
We saw that prevention is of course very important, but in a health personnel perspective, we need more health personnel for every increased living year, and to have more people living till they are 99 instead of 89 will demand higher personnel costs. It's very good that we live longer, but if we discuss the health resources, it's a sword with two sharp ends.
I guess we can agree that both prevention and secure enough personnel is important in all the countries. I think we're out of time, or I know we're out of time, so I want to thank all of you for coming here today, and thank you for joining us from Denmark and Sweden as well. Thank you.
All the best. Good luck on your week.
Thank you very much. Thank you.